Hello and welcome everybody to our TIF Talk Tuesday. We're so excited today to have our special guest, Dr. Sandhu, joining us this evening. Thank you so much, Dr. Sandhu, for joining us this evening. So, you're welcome. Thank you. So, as some of you that are watching already know, if you're following us and have been watching our TIF Talks every Tuesday, this is a live event. So at any time, if you have any questions, please feel free to type your question in the little chat section and we will do our best to answer your questions. In addition to having Dr. Sandhu here, we do have Wendy Profit, one of the market development managers for Endogastric Solutions. She will be joining us and asking all of the questions that are coming in live from Facebook. So Wendy, thanks for being here.
Thanks for having me.
Fantastic. So before we start, I do want to give you a little introduction on Dr. Sandhu. Dr. Bimaljit Sandhu is a board certified physician, gastroenterologist, and internal medicine, and has been practicing for more than 29 years. After completing medical school, Dr. Sandhu completed additional fellowship training in both gastroenterology and hepatology. He practices in Richmond, Virginia, where he treats a full spectrum of GI disorders, including GERD, Barrett's esophagus, cancer of the gastrointestinal tract, and pancreatic disease. In addition to being an advanced endoscopist, Dr. Sandhu has authored and co-authored several medical publications, has contributed to the American Gastroenterological Association Digestive Diseases Self-Education Program, and has served on the training committee for American College of Gastroenterology. He has been a visiting professor to Johns Hopkins, University of Pittsburgh, Stanford University, and the University of Virginia. So again, we can't thank you enough, Dr. Sandhu, for joining us this evening. We're looking forward to having a conversation with you.
Thank you very much, Andrea, and thank you to all the viewers who are spending some time this evening to have more education about the gastroesophageal reflux disease.
Fantastic. Thank you so much. So we'll just go ahead and kick it off right there. Dr. Sandhu, why don't you tell us a little bit more or describe what GERD is, what does it stand for, and also, what do you believe patients that are suffering from GERD, what do they come in complaining about? What are kind of the symptoms that?
Sure. So the GERD, this acronym stands for gastroesophageal reflux disease. This means when the gastric contents reflux back into the esophagus, they lead on to a variety of symptoms, typically heartburn, indigestion, trouble swallowing, sensation of a lump in the throat. And in some patients, the symptoms could be varied. It could be all the way up into the throat, where they'll have what we call laryngeal symptoms, chronic hoarseness, need to clear throat. So in short, it's the reflux of the gastric contents into the esophagus that lead on to a variety of symptoms. And this happens because of the weakness of the valve, or some mechanical disruption at the level of the junction of esophagus or stomach, what we call a hiatal hernia.
Okay, thank you for that. Thank you for that. Can you please tell us what you recommend patients to do if they're kind of just initially having those GERD symptoms? How do they manage their GERD? Is it, food aversions? Is there certain lifestyle changes that they can do to help them with their?
Yes, certainly. So the management of GERD starts with changing the diet and lifestyle. It is very important to understand what to avoid, and it is also important to understand how to eat and what to eat. Avoiding certain excess of caffeinated drinks, carbonated drinks, fatty foods is really important, and equally important is to eat small portions and eat slow, thoroughly chew the food before swallowing, and not to drink a lot of liquids with the meals, because all these will lead on to reflux. Not to eat too close to going to bed. So initial life and diet changes would be to eat smaller portions, eat slow, drink liquids, preferably water, in between the meals, not with or immediately after. Avoid excess of caffeinated drinks, avoid excess of chocolate, fatty foods, and keep the weight stable. Excess of weight around the abdominal area will also lead on to reflux. So having a healthy body mass index is also important.
Yeah.
Exercise is equally important as well.
Yes,
Eating and lying down. Yes, yeah.
Yeah.
So eating and lying down, not a good idea. So after you had a meal, try to stay upright, particularly during these dark winter days. Everybody tends to eat and sit in front of the television, watch games. Again, get up, try to get house, but try to be on your feet.
Yeah, that's a really good point. And, we've got lots of patients that are come on to these TIF Talks or have questions about, when is the right time for them to do something about their GERD or their, reflux?
So, if it is based upon the frequency of the symptoms, if it is maybe once a month or twice a month, certainly working on diet and lifestyle would be the most important thing. But if the symptoms are happening more often than that, which means they're happening maybe 2 or 3 times a week, then it's time to start considering taking some medications. Starting with the H2 receptor antagonist, which is either famotidine or cimetidine. They're available over the counter. Starting the smaller dose would be a reasonable thing. And if the symptoms are not controlled with the 2-week therapy of that, then maybe switching to the stronger medication, which is a proton pump inhibitor group, something like omeprazole, Nexium over the counter, the purple pill, something from that group would be helpful. And again, take the over-the-counter dose for a couple of weeks, see how the response to the symptoms is. And if they are persistent, despite all these measures, then certainly talking to the primary care physician or the gastroenterologist would be the next step.
Perfect, thank you. There's often debate about long-term use of PPIs. Is it okay for patients to take it longer than the original 2-3 weeks that they're supposed take it to see if it helps them with their symptoms? Do you have any recommendations or thoughts around long-term use of?
Right. So in the past several years, we have recognized there are several papers that have come out which have given us the side effects of long-term use of this subgroup of medication, the proton pump inhibitors. Folks can get early dementia. It can affect the kidneys. Of course, when you're shutting down the acid from the stomach, what is important is acid is a housekeeper for the GI tract. So if you shut it down too long and too strongly, it leads on to other problems in the GI tract as well. It can cause some cardiovascular abnormalities as well. So taking it long term, we are recognizing that it's not really a great idea. So if one is taken for 6 months and symptoms are still ongoing, it's time to consider what we need, to go to the next step.
Perfect, thank you for that. Now it looks like we've got quite a few questions that have popped up from our Facebook viewers, so I'm going to pass it on to Wendy to go ahead and.
Well, thanks. These are coming in at a perfect time as you're discussing, your diet, lifestyle modifications. Richard is asking, just can you give me any safe foods to eat? It sounds like he's really been struggling and is just looking for something that might be, a universal safe thing to use.
So, there's not one size fit all, but what's really important in this kind of situation is to avoid too much of grease, too much of fatty foods, too much of spices. Some people can handle spices, but a lot of spices are not really good. What fatty foods as well as excess of caffeine does is it decreases the strength of the lower esophageal sphincter. It makes it lax. So things are going to reflux back. Eating bigger portions is also something that one should avoid. But some people will have more symptoms with citrus-based foods, like oranges, anything of that sort will give problems. Tomato-based foods will cause problems to certain patients, so try to avoid that. What is really important is try to figure out what is really hurting you and try to avoid those foods. But in general, if it is a well-cooked, fresh food, I think that's the best food. Anything that comes out of a freezer, anything that's processed, it's not really good. So freshly cooked home food, I know it cannot be always possible because of the work-life balance can be a little difficult. But if it is not really a processed food, less spices, home cooked, even though it can be refrigerated for a few days, that'll be a good food.
Before you go, Wendy, I do want to mention, Dr. Sandhu, you mentioned something really good about, kind of tracking and understanding what foods trigger your GERD. We actually have an app. You can use it on your phone, whether iOS and or Apple phone, and it allows you to track your foods and then what symptoms are, giving you, which foods are giving you some symptoms. So that would be an interesting way to kind of track which foods are actually causing the acid reflux to allow them to, start avoiding them if they need to. So if you want that app, it is the GERD Help app. You can just search for it on your app, on your app store, if you will. So sorry, go ahead, Wendy, and thank you, Dr. Sandhu. Were you going to say something?
Make a point. Another point. One of the things which most of us don't do really well is have a good breakfast. Our way of life is get up, get running, grab a cup of coffee, either make a cup of coffee at home or just grab it at work, and no breakfast. So just imagine your stomach, which has been producing acid all night. The acid secretion peaks up in the morning around 3 or 4 a.m. and body starts to get ready for the day's work, and all those hormones are revved up. Acid secretion starts getting much higher and higher. And on top of it, we chug coffee. We're just making things worse. It could be just a small helping of oatmeal, or you can have a fruit parfait. Just have a cup of yogurt. Just put some fruits in that, some nuts, and have that. Even though if you have it on the go, that'll still be much better than a cup of coffee in the morning.
That is such a good point, and no one's ever really talked about that. And I suffer from GERD, and I do the same thing. I'm like, oh, I'll just have a cup of coffee, and I'm wondering why I feel so sick, up until lunchtime because I haven't eaten anything. So it's a really good point. Thank you for pointing that out, Dr. Sandhu.
Yeah, I think a lot of us just say, "I irritate my stomach, but I have got to have some coffee." So that's an excellent point. I'm sure that we'll probably have a couple of more questions come from that in the weeks to come. So Richard, who asked the previous question about diet, is also asking, and he didn't clarify one thing, but I'm just going to make the assumption here. He's asking how he heals after a reflux episode. Is there what can he do to help speed that along?
So if a reflux episode happens, and again, it has to be very carefully thought through as to when the reflux symptoms are happening, whether the symptoms are happening after one eats or the symptoms are waking one up at night, because they carry a different significance. If one is having constant symptoms of reflux at night time and they are eating maybe around 5:30 or 6 p.m., still upright for some time and still have symptoms at night time, I think that is a suggestion that there could be some anatomical disruption like a hiatal hernia or a weak valve that could be triggering it when one is flat because gravity is not helping. If the symptoms are happening after a big meal, we need to cut down the portion. And one very simple thing which a lot of us don't recognize is we chug about 8 or 10 ounces of water with a meal or immediately after. That's not a good idea. Try to just have a sip or mouthful of water to wash it down. Don't drink a lot of liquids. And most of the times we should drink water, which is actually the best form of liquid God created. So, drink water preferably and not carbonated beverages. And that too, just a little bit, 1 or 2 ounces. Rather, sip water in between the meals. That's the best way, because you're not increasing the stomach volume. And when the stomach volume goes up, as the stomach is churning the solid food, the liquids will come back to the path of least resistance. And that's what happens in people who are predisposed to reflux. So don't drink a lot of liquids with the meals, space them out.
Excellent.
Yeah, like this big bottle of water that I have.
It's
You're
still
just
good
getting
to
busted
drink
all
water.
over the place, Andrea.
Just don't drink it all at once. I try to drink it all day long.
And also, just like the grandma used to say, give each tooth an opportunity at the food. So meaning chew, 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 and make it paste before it goes to the stomach. Because when the stomach is, a lot of people have a misconception that stomach digests the food. Stomach does not digest the food. Stomach beats it down into smaller portions, mixes with acid and the pepsin, and it makes it into tiny pieces. And how does it do it? By squeezing on it. And when the stomach squeezes on the food, and if we have topped it up with a lot of liquids, as the stomach is squeezing on it, liquids will come back up.
Wow.
So if you have chewed your food really well, stomach has to work less.
Very good.
Okay.
Wow.
I don't think that we've ever had really the physiological description of how digestion takes place. So this is fascinating.
Yeah.
I have one more question and then I'll turn it back to you, but this will kind of take us into the next phase of our discussion, which Mr. Oldine's asking. I've had my esophagus stretched, but I'm still having issues with my food getting stuck. What is my next plan of action? And the reason I asked that one is, can you talk a little bit about, before you jump into her question, can you talk a little bit about the testing that is done to determine whether or not someone actually has GERD?
So endoscopy is one of the procedures that we do to assess for when one has symptoms which are persistent despite taking the medications, or when the symptoms recur if they stop medication. So to assess what's going on in there. The different ways to assess for reflux. If you go in there and we see a lot of inflammation at the bottom of esophagus, what we call esophagitis, that's pretty suggestive. If you see presence of a hiatal hernia and there's some inflammation, again, it's pretty suggestive. Some people will have what we call NERD, which is non-erosive reflux disease. Biopsying the lower portion of the esophagus will show some mild reflux-related changes in some situations, and that also consolidates the diagnosis. In situations where there's not much that is to be seen with endoscopic visualization, or some people have symptoms which are atypical, which are what we call laryngopharyngeal reflux, having symptoms all the way up in the throat. We want to be sure that this is indeed coming from reflux. Then we go to some physiologic tests like doing the pH monitoring. And there are different ways of doing the pH monitoring. Either we place a cordless or wireless transducer in the esophagus with endoscopy that measures the pH. There's a small device that you keep beside you. You do all the things as you would do on your day-to-day basis, and that'll send the signals to the transducer. And once we record it, we'll be able to see when one was having reflux, whether it was after eating, lying down, walking, talking, sleeping. So we'll have all the symptom correlation with when the person has reflux. So that's another way. That's called Bravo pH monitoring. There's another way of putting a small catheter through the nose. Not very convenient. It'll be a small catheter hanging through the nose. Again, it'll measure the pH. There's another way of assessing reflux, and that's by the radiological testing, which is making you drink a contrast, which is the barium, and then assessing whether things are coming back or not. So those are the ways to assess for reflux. And now your question about having the esophagus stretched and symptoms still coming back. What happens is in some of the younger folks who have reflux and they have trouble swallowing, commonly there's a condition called eosinophilic esophagitis where there's some sort of dietary or environmental allergy that triggers clustering of these eosinophils, and they'll cause more rigidity in the esophagus. That is one thing that can cause reflux. So if it's a younger person, ruling that out with a biopsy is important. If somebody has just plain simple reflux, there could be a complication of reflux, which can cause trouble swallowing and things can get caught. And that complication is called a stricture, where constant bathing of esophagus with acid leads on to inflammation, and inflammation heals with scarring. And that's what leads on to narrowing. And in some folks, there's neither of these present, but they still have this trouble swallowing, and that can be from either this motility of the esophagus, where esophagus, which is just a conduit, it's a muscle which propels the food bolus down into the stomach. That contractility is not as effective. That can cause trouble swallowing as well. There's another problem that can happen when acid comes back into the esophagus. Acid doesn't belong there. Esophagus doesn't like it. So how does it push it down? By squeezing. So folks with persistent reflux can also have spasms, and that can give a sensation of something being stuck there or trouble swallowing. So they're different. Sorry, this is a long answer, but this is trying to explain all possible situations and scenarios that can cause that.
I love that. I love how thorough you are, and there's a lot of the topics you just discussed we've never discussed, and we've done TIF Talks every Tuesday. So this is really nice to hear kind of all of the different scenarios that could happen. So Wendy, I'm going to go on and keep moving, and we can answer some more questions as we go. But let's talk a little bit about what are the options right now that are available to treat GERD. Obviously, back in the, you talked about the medical therapy, PPIs, and medication, and maybe you can talk a little bit about Nissen, fundoplication, and then where the TIF kind of falls in place throughout the.
Sure. So, once we have determined that a person is requiring long-term proton pump inhibitors, or the symptoms are not really well controlled with those, or they get side effects from that, and of course, with more and more awareness, people would not want to take these medications, and how do we control their symptoms and not have them have long-term complications from reflux? That's the time when we have to go to the next step of preventing the reflux, not just by shutting down the acid. It's not just the acid alone, it's the volume regurgitation that also causes problems. So why does reflux happen? So there could be, we have to understand that physiology first. The lower esophageal sphincter muscle, it's an arbitrary high pressure zone between the stomach below the diaphragm, between the stomach and the esophagus. So that prevents things from coming up. That's what we call the flap valve. When that is weak, that leads on to reflux. There are some ligaments that hold, like the ropes of a big pole, which is holding a flag post. So if those ropes, which are the phrenoesophageal ligaments, if they become weak, esophagus doesn't return back to the G junction doesn't return back below the diaphragm, and that's when the exposure to acid happens. So how do we reinforce them? One is, and this has been oldest way of doing it, is the Nissen's fundoplication. So there's a wrap of the portion of the stomach which is put around the lower end of the esophagus, and that wrap, it enforces the junction of the esophagus and makes the flap valve a little more stronger, and things don't come back up. Now it's a 360-degree wrap. It's been there have been some iterations to that now, but there are some complications with that procedure. One is that this is more invasive. Number two is this can lead on to some very simple but debilitating problems. Gas bloat. We say, oh, I'm bloated all the time, but just imagine if somebody's bloated 24/7, they can't get comfortable, can't sit on the chair properly without relaxing and just sitting upright. So always have to constantly move around, wiggle around. Imagine doing that in a meeting or in a situation where it's just really awkward. A lot of people will have flatulence and gas. We just can't. It's about 60% patients can have that kind of problem. So those complications, even though they sound very simple and minimalistic, but they are life-changing for some patients. So what do we do next, which is less intrusive? There have been some studies about doing the placement of magnetic beads around the G junction, which is called the LINX procedure. Again, putting anything mechanical around any hollow viscous in the GI tract, there's a risk of erosion. And again, it cannot control the symptom. It doesn't enforce the valve all the way. There has to be some fixation of the hernia. And of course, as the way the GI is progressing and surgery is progressing, there is room for minimally invasive procedures, and that's where the TIF comes in. The TIF acronym stands for transoral incisionless fundoplication. So this is a procedure which is done through the stomach, through the esophageal lumen, and this device goes over the endoscope. So we do it under direct visualization, and it happens over the bougie, which is the TIF device itself. So it gives us enough room around the esophagus when we are creating this prolongation of the flap valve. It can never be tight enough to cause problems with gas bloat, so folks are able to burp. Those complications of gas bloat, diarrhea, and bloating and gas and flatulence, they're not there. This is a minimally invasive procedure, can be done as an outpatient. Some patients stay overnight, but if it is just a plain simple doing TIF, then it is, some people would go home the same day. There's some dietary restrictions after that, but it is very minimally invasive and it's got very minimal complications. It's very, very safe.
Perfect. Yeah, thanks. Can you just talk or touch on, what happens if someone also has to get their hiatal hernia fixed? How does that work with the TIF procedure?
So with the TIF procedure, there are two different varieties of TIF. One I just mentioned about, which is just plain simple TIF. We do this in patients who either don't have any hiatal hernia or the hiatal hernia is smaller than 2 centimeters, which means it's smaller enough that we can, after extending or prolonging or enforcing the valve, things will stay in the intra-abdominal cavity. If it is a bigger hiatal hernia, bigger than 2 centimeter, then it's advisable that we do a combined procedure where we do laparoscopic cruroplasty, where the crura of the diaphragm, which is the muscle which allows for this diaphragm, for the esophagus to go down and stay in place in the stomach, that crura becomes weak and we enforce it by putting 2 or 3 sutures depending upon what is required. It may or may not require a mesh, again, depends upon the choice of the surgeon and of course the size of the hiatal hernia. But again, it doesn't add too much of morbidity. It doesn't add to any change in the outcomes. Folks could still go home the next day, and the outcomes are pretty, pretty marvelous. There's about 80 to 85% of patients will be off of acid blockers for a sustained period of up to 5 years. So the studies have shown that it's a pretty durable procedure and gives a lasting relief. Just imagine, not having to pop a pill every day, and of course, not to have side effects.
Yeah, perfect. I do see a question that just popped up. Who is eligible for the TIF procedure?
So it's a great question. It's a patient who's been having reflux symptoms and has been having symptoms for about a year or so, and has not had much relief with the acid blockers, or requiring higher dose of acid blockers like the PPI. I think that would be a good candidate.
Perfect. Thank you. Can you talk a little bit about recovery? What can patients expect after having the TIF procedure? One of the big things that everyone talks about, obviously, is the diet. So maybe talk a little bit about what do they expect after having the TIF procedure and how does that diet progression look? And then also, how quickly can they go back to living their normal life after the TIF procedure?
Sure. So, again, when we do this TIF procedure, what we're doing is we're prolonging the valve where the esophagus is pushed down into the abdominal cavity, and we are putting sutures where the esophageal valve is prolonged. So we have to allow for the sutures to hold in place and allow for the 2 layers of the esophagus and the portion of the stomach to fuse and stay fused for a prolonged time to prevent any complication, not really complications, any failures of this procedure. So diet and lifestyle are very, very important after the procedure. Immediately post-op, what we recommend is folks stay on liquid diet for, they stay on clear liquid diet for about a week or so. It's very important because anything that will cause nausea, anything that will cause retching or vomiting, that can cause the failure of this this procedure that we did. After that, advance the diet to soft, which is full liquid diet. Folks can have smoothies, folks can have shakes and all, or just liquid diet preferably. And then eventually it has to be about a 4-week process where the diet is slowly advanced week by week based upon the progress and presence of symptoms. If the symptoms are not there, like nausea and vomiting, it can be changed on a weekly basis. Activities are very, very important. Again, anything that will increase the intra-abdominal pressure, coughing, sneezing, constipation. If one has constipation, make sure that don't strain too much. Take some softeners proactively to go to the bathroom. Don't lift heavy, don't exercise. It's okay to walk around the house after a week or so, but not really heavy exercise. Running, jogging, lifting weights should be avoided. And then again, acid blockers are important. We do recommend that they take acid blockers for about a month or so because there'll be inflammation there, and that'll prevent ulceration and also take away the discomfort that could happen from the procedure itself and the ulceration that happens from putting the sutures in there and the device.
Perfect, thank you. We do have a couple of questions about PPIs again. Viewers are asking, how long should they take them? And I know you discussed it a little bit at the very beginning of the conversation, but how long should they stay on them to stop them from any potential health risks moving forward?
So under the presence of underlying conditions is important. If one already has underlying conditions where the kidney dysfunction is there, heart dysfunction is there, they have to be really careful. They could be, till now we have been giving these for several years. Patients have been taking, not recognizing that they will have long-term side effects. But the short answer is, if they take for 6 months and the symptoms are still ongoing, I think that's the time to reconsider what we're doing.
Yeah, perfect, thank you. So living kind of GERD-free after they have the procedure and they do, the diet protocol and heal and whatnot, are most of your patients off of PPIs, or do they continue to still take PPIs?
Most of the patients, like I mentioned earlier, there's about 80% of the patients will be off of PPIs, so they will not have to take any acid blockers. So again, just taking away the acid blockers alone can help with a lot of bloating, because taking away the acid will lead on to promotion of growth of certain bacteria which are not really friendly to us. Acid clears out the unwanted bacteria as well. So acid is important. It was created for a reason. So by shutting it down for too long, it's not a great idea. So stopping that will help with a lot of symptoms besides, the not have to take it for the reflux anymore.
Yeah, fantastic. Well, we're so excited that you are here today to explain answer all the questions that our viewers have and explain, GERD and the TIF procedure. If you had one major advice for patients that are suffering from GERD, what would that be to them?
Okay, so if one has persistent symptoms of reflux and you've taken the medications and you've done due diligence with your diet and lifestyle changes, and symptoms are still ongoing, I don't think, with this day and age, with the advances in the treatment options and of course, with the TIF at hand, don't prolong your symptoms for too long, because prolongation of symptoms leads on to complications. If one develops strictures or narrowing in the esophagus, it might even preclude us from doing a TIF, because we just can't jam this device down the esophagus, which is already narrowed. So taking action at an appropriate time is very, very important. Don't prolong the symptoms for too long, and one could have a quality of life with this procedure and not have to suffer. Prolonging the acid reflux without adequate treatment also predisposes one to have precancerous condition called Barrett's esophagus, and then we enter into all sort of surveillance, and we can't do a TIF procedure unless the Barrett's esophagus has been adequately ablated. So first, we'll be going down and treating the Barrett's esophagus with endoscopic treatment. Then we'll be following every 3. So it puts things behind, by maybe a year or so, because it takes about, on an average, 2 to 3 sessions to completely ablate the Barrett's, depending upon the length of the Barrett's and the severity.
Yeah, I'm glad you mentioned that. Back in April was Esophageal Cancer Awareness Month, and ironically, now in November is GERD Awareness Month, or a GERD Awareness Week, I should say, the week of Thanksgiving. Eat a lot of food in a shorter period of time. So it's good that we, one of the things we like to do is raise awareness around GERD, and you're helping with that. So we really appreciate it. If you guys are watching tonight and you are in the Richmond, Virginia area, that's right, Dr. Sandhu, Richmond, Virginia is where you're located. You can contact Dr. Sandhu's office. But if you are not in the Richmond area and you would like to find a TIF specialist in your area, you can go to gerdhelp.com. There is a physician locator there. You just type in your zip code and or state, and you'll be able to find a local physician in your area. So any final thoughts or say adieu to everybody watching?
I think I would like to conclude, since you mentioned about the Thanksgiving, we all are guilty of showing gluttony at one point or other. So it's really important to take charge of your health. The bottom line of America is growing, so we need to make sure that that's not really the case. So eat healthy, stay healthy. It's not just the reflux alone that's a problem there. Poor eating habits lead on to vast variety of other problems. Like they say, you are what you eat, and so have good eating habits, good lifestyle habits, and stay healthy.
Fantastic. Couldn't have said that any better, Dr. Sandhu. Thank you again so much for joining us this evening. I know we at EGS really appreciate your time, and I know that people that were watching appreciate it as well. So thank you very much. Have a great evening, everybody, and we'll catch you next Tuesday for our next TIF Talk. So have a good night, everyone. Thank you very much.
Thank you.